could affect your right shoulder because through the fascia. And that's true of all the muscles in your body, but this is a particular connection. And the lats actually function as an accessory breathing muscle. So that's just interesting. So the lat muscle assists in humeral depression and adducts. So it adducts. That means I say add. It's adding to the body. It brings closer to the body. Your arm brings it this way, and internally rotates the humerus. That's this way, which most of us don't like to do because it's uncomfortable. And when the arms are fixed overhead, it pulls the trunk upward. So the lats are used, especially in the beginning of a pull-up. The lats are what initiate that first move. And if people don't have strong lats, they're not going to be able to do a pull-up. It's one reason that you put, this is kind of on the side, you could put something that will support you on a chin-up bar that's got some give to it, like a rubberized, stretchy. So it kind of helps you get that first move, and then the rest of your body can take over, but it's a good thing to know. The levator scapula, it's a long, thin muscle that connects on the vertebrae, the first four cervical vertebrae, and it inserts on the medial border of the scapula. Its primary function is to elevate and adduct the scapula, and it tilts the glenoid cavity inferior, so it rotates the scapula downward. That muscle is, levator scapula means elevate. It sometimes people think they have track pain, but it's a levator scapula that just gets, when we hold tension under like this, it's really getting irritated. People who have forward head posture often have just extensive levator scapular pain. And one of the best ways to relieve it, interestingly enough, is to lay them down and put their head on a block. So they're laying down and their head is rested, and it lets those muscles relax for a change. And then the rhomboids, there's two, a rhomboid major and minor, and they're responsible for retracting and elevating the scapula. We're pretty familiar with those when we think, if I ask you all to retract your scapula, pull your shoulder blades together, you're using your rhomboid muscles there. And slouching stretches those muscles. And if we stretch them a lot and we don't use them much, they forget how to retract. And so you have to teach them. And you can always teach muscles. Even if they've lost the neuromuscular connection, you can teach them again. Unless there's like some stroke, some kind of nerve damage that is really permanent. The deltoid muscle is it's composed of 3 fibers, similar to the trapezius. You have the front, or they call them anterior, the middle, and the posterior. And they all attach to the humerus, come around here, and they attach. And so they're primarily responsible for abducting your arms. Okay? And the teres major, it's a small muscle that sits alongside the teres minor. I don't know if I put a picture of it in there. Yeah, I did. Mm-hmm. So it's sometimes called the lat's little helper because it helps the lats do its thing. It does very similar range of motion. So the triceps, there are 3 muscles on the back of our arms called triceps, and one of those muscles, it's called the triceps brachiae longus, attaches to the scapula, the neck of the scapula here. Okay? And so it originates here and inserts into the ulna. In other words, its insertion is D4. Anyway, and so it contributes to extension and adduction of the humerus. Okay, so the tricep is involved, helping with that. And then the front muscles, these, the ones that we're going to go over, help to stabilize the shoulder. So the sternum, this is a neck, you think of it as a neck muscle. It's a sternocleidomastoid. And it originates in the middle of the manubrium. And, excuse me, down here on the sternum. And then inserts into the mastoid process of the skull. So it doesn't actually move the shoulder, but it can be influenced by shoulder movement or shoulder dysfunction, and of course forward head posture. There's a picture of the forward head posture that shows you. Yeah. So when we have forward head posture and that starts getting shortened, that can affect the way you can move your collarbone and your shoulder. So forward head posture is like, you don't want it. The pec majors, they're the broad chest muscles commonly known as the pecs. We think of them in weightlifters and bodybuilders. All of those insert into the humerus. They come across, these don't roll very well. Those broad chest muscles come across and insert into the humerus right there. So they're involved in adduction and internally rotating the humerus. And then the clavicular part, where they attach across the top of the clavicle here, and then they attach all across the front of the spine, the sternum. They help to lift the arm up to 90 degrees, and this part helps to lower the arm. Sternocleidomastoid, yeah. And then the pec minors is just a small muscle that's underneath the pec majors. It's deeper than them. It is one of only 3 muscles that attach. So remember I said that this is the only bony attachment? So there are 3 muscular attachments that attach the upper body to the shoulder to the upper body. And this one is one, pec minor. And the others are the pec major, the subclavius, and the serratus anterior. The serratus anterior we're going to talk about next.
So is that kind of an important point, that it's just those 3 muscles that attach to the shoulder function?
That attach the
appendicular skeleton
to the axial skeleton, yes.
Right, so that, yeah.
Mm-hmm. Yeah, it is. And the fact that the shoulder is only connected here.
Exactly.
Bony connection.
Yeah.
It's like, wow. So the pecs have a pretty profound effect on shoulder function. And most people who, bodybuilders, they ultimately end up with dysfunctional shoulders because they're pulled forward. And so if you look at their backs, they have big, broad backs that look really strong, and they have big, broad chests that look, but their shoulders, unless they really work to keep as much range of motion in their scapula, they're not going to be able to bring their hands over, their arms up overhead, externally rotate all the things that they might need to do. So the serratus anterior muscle originates on the ribs, and let's see, here, sorry, these ribs, and they, this one's kind of a complicated one. It's separated, so this is the one that it comes across here and it attaches here on this scapula. So this is one of the places where the body is attached to the shoulder, to the back of this little serratus anterior muscle. And if you look at the diagram, you can actually see how this scapula in that second picture is pulled away like this to show you how that scapula is attached.
Which is that?
And the
Grace?
serratus,
I'm sorry.
page 13, the
Oh.
second picture of the serratus.
Oh.
So, sorry, I'm sharing yeah, they have that.
Maybe you can just show.
Yeah. This is actually called the boxer's muscle because it's used in protracting the scapula forward like that. So the serratus is considered the boxer's muscle. It's also a shoulder stabilizer. It keeps the shoulder blade against the rib cage, and it acts synergistically with the rhomboids. So if you're doing a plank, for example, a side plank, you would be engaging the rhomboids and the serratus, among other muscles, to keep that shoulder stable. So they're working together to keep you from sliding forward or back. The biceps tendon, the long head of the biceps tendon comes up and attaches deep. It comes up through this little bicipital groove and attaches inside, goes under the head of the humerus and attaches at the top rim of the glenoid cavity. The poor little guy, it's amazing that they function as well as they do, as long as they do. And there's a little tiny piece of ligament that crosses over that groove to help hold that tendon in. Because if you're going like this, or certain moves like this, actually, this way, that's going to get loose in there unless there's something holding it in. And so when that little piece of ligament gets torn, then your bicep tendon is going to start jumping out of that groove, and you know it when that happens. So that can be problematic, and they can surgically repair it, or sometimes people tear a biceps muscle, and then it'll tear up here, and it'll just fold down into a big wad down here, and they may not do anything about that. They may just leave it there, because the short head of your biceps will take over and do what it needs to do to bend your arm. So, and the biceps, of course, helps to flex the arm, and it also acts as a major humeral depressor. It helps keep that humerus in the cavity, the socket of the shoulder. So we're moving on to, bicep tendon issues are often associated with rotator cuff issues. Yeah, like almost pretty much. There's a small muscle called the coracobrachialis muscle, and it just attaches from here to this little coracoid process to the humerus, and it helps with flexion of the shoulder. The shoulder ligaments, you can look at that picture, and I'm not even going to go over any of those. They just attach the bones to the bones. If you have a ligament tear, it can be a problem. And if ligaments get stretched out, it can be a real problem because there's nothing to get them to go back to where they were. So, most injuries that involve ligaments are the result of a fall causing muscle or tendon tears. Partial or complete dislocation of the shoulder, which is what I had many times, or even a broken clavicle or shoulder bone. Okay, and then now we're going to go over functional movement. Does anyone have any questions yet? Yeah.
So how do they diagnose these things? Is it an MRI or how do you know which part of your shoulder is messed up?
Sometimes there are really good clues that a doctor can tell exactly what's going on, and it basically has to do with range of motion, the amount of range of motion that you still have, and the pain that you tell him you have when he, for example, asks you to externally rotate this way. If you have certain pains back here, he'll know what kind of impingement you might have. If he has you do this and he presses down, he'll know. And I'm not going to go into all those details, but they can tell pretty much with functional tests. It's not 100% reliable, in which case they might order an X-ray if they feel like it's a bone issue, and an MRI if they feel like it's a tissue issue. And still, oftentimes they don't really need to know exactly what's going on. They just say, your shoulder's not functioning right, so you need physical therapy. And the therapy is going to be similar for everyone, no matter what their injury is, essentially. Not always, but if they have an impingement, whether it's the acromion or the coracoid process, or there's another one we're going to here. It's just, you can't move without pain, and so they just slowly work at getting you to have more and more movement with the various ways of therapy that they're going to employ. Does that answer your question?
Yes.
Sort of. Any others? Okay. So functional movement of the scapula include elevation, so that's where the scapula rise. Okay, and you can see on the pictures here. Depression is where you lower your shoulders as low as you can, the scapula lowering down. Adduction, which means you're taking your arms out to the side, and so your scapula are coming in closer as you do that. And then abduction, where you're essentially, I call it protracting. You know, you're moving this way. Upward rotation, so when you raise your arms, your scapula have to raise, otherwise it would impinge on here. And that there's a certain number of degrees that the arm will raise by itself without impinging at about 30, I think it's 30 degrees. And then for the next 30 degrees, the scapula has to rotate. And then beyond that, the scapula won't rotate. And this is just a terrible little guy. Can't really show you. So,
Maybe.
If your scapula is not going to move like that, you're not going to be able to raise your arm.
It looks like he's suffered some tissue loss.
Some screws came out. Yeah, some screws came out.
He seems to be smiling. Doesn't that look? Yeah. So the scapula will also tilt this way, anterior, like if you were extending, or posterior, up to the point where the ribs meet it. And they say rotate, abduct, and protect. We already went over those things. Oh, and then when you externally rotate your arm, so if you say you have your arm bent like this, and you externally rotate like this, this has to move a little bit. It's obviously limited by the ribs, but it moves a little bit. Okay? And the same as when you come this way. I think there were pictures of that too. The next page, the tilting. So basically a scapula, this little winged guy, plays a key role in every aspect of normal shoulder function. It makes up 30% of upper arm movement. So during any movement of the humerus of the shoulder, when the scapula moves, the humerus and clavicle move. This is really important, and it should be obvious, but it isn't to us until we learn. So even minute movements of the scapula. So in other words, if you just sit here and gently retract your shoulder blades, you just externally rotated your humerus. It's not a lot, but you did. And if you have issues, that might cause pain. It's one of the things in physical therapy, which is gently trying to restore all the movement that you can accomplish. And I already went over the degrees that it will move. So any disparity in position or function of the scapula is important to address in therapy. So, so if a person comes, I'm just going to speak from my experience. If a person comes to me and I look at their back and they have one shoulder that's winged out like this and the other that's not, that's called a disparity, scapular disparity. And that's problematic. I mean, I know right away that they have issues with their shoulders. They may not have any pain, they might not even realize that they have issues, but the development between the muscles, the ability to move and everything is going to be different. This is, in people who have scoliosis, you almost always see a scapular disparity. And that's one of the first things we address in scoliosis, is to try to get the scapula to function as quickly, as functionally as they can, given their issues. And so we work more bilaterally, one side, getting the dysfunctional shoulder to work a little better, and then get them working together. And that actually helps with the rest of their scoliosis issues. So even if they have their pelvis is way out this way and they're this way, we're going to work on the shoulders first, generally. Okay, and then the humerus bone moves by itself, independent of the scapula. So it goes flexion, extension. I said independent. They're not independent. I was thinking of something else. Anyway, so we went over all these, but these are when you think of the humerus bone, it's flexing here, extending here, abducting. Abducting. I would do that. Abducting forward. I might have to end up buying this. I borrowed this, and the person I borrowed first said, "Do you want to buy it?" I said, "I don't think so." A brick and I have to buy it. Okay. Any questions about any of that?
What can you do for scoliosis? Like you were describing a little bit, starting with the shoulders, but is that like how much of a difference can the osteopathic method make for that?
It depends on who you talk to.
I'm talking to you.
So I don't think I have any of my, maybe I did bring some before and after photos of scoliosis. These are not mine, they are from the course, and they will show you.
Did you bring your card? Because I'm going to want to have that for referrals.
So this is a young woman who has scoliosis, and this is after one session.
Wow.
But that's not going to hold.
Yeah.
She has to do this every day of her life because her muscles, this is one of the things about our body, is we develop, it's hugely adaptable, and when it doesn't function right, when the muscles are not functioning correctly, it says, well, you want me to do this, so I'll recruit some other muscles to do it. And so and this is a young woman, she's like 21, I think. And I think she's had scoliosis for quite a while, but it's not real severe, not like some of them like you see. But her body is basically pulling on one side, stretching on the other, and so it's used to doing that. And it takes a lot of work.
I just love that because in massage school, half of our teachers were saying, oh, you can't do anything for scoliosis, and then half of our teachers were saying, oh, you can, in some situations.
Yeah, and it's massage is hugely helpful, but they have to learn to exercise the muscles that are out to lunge, and stretch the muscles that are too contracted, and do it every single day. And they have to learn, and posture therapy teaches this, you have to learn how to recruit the muscles properly. That's the key. Getting the muscles, like if you want to tilt off to the side, you have to recruit the right muscles. And it's not that you have to think a lot about it. It's just that you have to learn how to do it.